Good morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. On behalf of our President, Professor Yoko Kaito, and the entire team of ACNS, let me extend our heartiest greetings to all our wonderful audiences in China on this occasion of the Chinese New Year. The speaker for the first session of today is our honorable faculty from India, Dr. Jagatlal Gangadharan. Dr. Jagat heads the Department of Neurosurgery at the Rajagiri Hospitals, Kochi, Kerala, India. He is a former associate professor from the National Institute of Mental Health and Neurosciences, Bangalore, and he was a former fellow for the minimally invasive neurosurgery and endoscopic skull-base surgery from the New York Presbyterian Hospital, USA. He has also received his ASAN ambassadorship in functional neurosurgery from the West Virginia University, USA. We are extremely honored to have him today with us, and he will be talking about safety in endoscopic endonasal pituitary surgery. The speaker for the second session of today's webinar is our honorable guest from China, Professor Lin Jingui. Dr. Lin is an associate professor at the Associate Professor of Neurosurgery at the Ningbo University affiliated First Hospital. He is a member of the Youth Committee of Neurosurgery branch of Zhejiang Medical Association, and his clinical interests are focused upon cerebrovascular surgery. We are extremely honored to have him today at our webinars, and today we will be talking about analysis of rescue strategies for acute thrombosis in Moyamoya patients during STA-MCA bypass surgery. The chair for the first session of today's webinar is our honored guest from Tokyo, Professor Hirotaka Hasegawa. Dr. Hasegawa is an assistant professor, Department of Neurosurgery, the University of Tokyo Hospital, Japan. He is the chief endoscopic skull-base surgeon at the University of Tokyo Hospital, who has abundant clinical and research experience in endoscopic surgery for skull-base lesions, including pit nets, meningioma, chordomas, and chondrosarcomas, as well as SRS for brain neoplasm and vascular malformations. He was a past fellow at the Mayo Clinic Neurosurgery at Minnesota, USA. He has been honored with several awards and honors during his career in neurosurgery. We are extremely grateful to him for accepting our invitation to chair the session of Dr. Jagatlal. The chair for the second session of today is our honorable faculty from Japan, Professor Nakao Ota. Dr. Ota is a Vice Director in the Sapporo Teishinkai Hospital Stroke Center, Department of Neurosurgery, Hokkaido, Japan. His clinical interests are focused mainly on cerebrovascular surgery. He is an invited faculty for various workshops and conferences conducted worldwide. He has published several articles in various peer journals, and we are extremely grateful to him for accepting our invitation to chair the session of Dr. Lin Jingui. On behalf of the Education Committee of the ACNS and Professor Yoko Kaito, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. And with that introduction, I would like to hand over this podium to our first chair, Dr. Hirotaka Hasegawa.
All right, thank you very much. Okay, great. So first of all, thank you very much for providing me this great opportunity to chair this session. So I don't want to take too much time because, many people are waiting for the great presentation from Professor. But before starting it, let me briefly talk about surgical complications in pituitary surgery. So, that endonasal surgery is a minimally invasive, but what about the surgery? What about the safety of it? There have been a bunch of publications describing the, possible complications of endoscopic and endonasal surgeries. Briefly, there are several, types of complications possibly happens during, endonasal pituitary surgery, which include rhinological, CSF leakage and infection, vascular injuries, endocrinological complications, neurological, others like DVT and PE, and mortalities may even happen. So to me, surgical safety is to avoid complications. So to do that, it's very important to understand the risk factors, and then we can, learn how to avoid it and how to manage it. So today's talk is from Professor Jagatlal Gangadharan. He is an expert in brain tumor surgery and many other surgical fields. And his main talk is safety in endoscopic endonasal pituitary tumor surgery. So please start your talk, Professor.
Thank you, Dr. Hirotaka Sugawa. So the topic of my presentation is safety in endoscopic pituitary tumor surgery. At the outset, I would like to thank my teachers, Professor Chandramali, Professor Theodore Schwartz, and mentors, great guides in the field of endoscopic skull-base surgery. I'd also like to thank Professor Yoko Kato, who is a beacon of neurosurgical education in the whole of Asia, and Professor Raja Kuti, Chairman of ACNS Education and my great friend. When we talk about pituitary surgery, we should start with the evolution of endonasal surgery. It was Oskar Kirsch who did the first endonasal submucosal transseptal pituitary surgery. And on the same day, on June 4th, 1910, Harvey Cushing in Boston did his first sublabial transseptal approach to the pituitary gland. However, due to complications like bleeding and infection, it was abandoned in 1920s in the USA. But later, Dr. Hirsch went to Boston, but the real resurrection of pituitary surgery started later when Norman Dodd pioneered transvenoidal pituitary surgery with 0% mortality in 80 patients. That was in early 1920s. The first endoscope, as we have seen today, a model of it was first introduced by Gerald Guy in 1956. And it was Jules Hardy who developed the microscopy and the instruments which we even use now. Modern series of endoscopic pituitary surgery started much later in 1997 when it became much publicized all over the world. And we should also thank Kapavian et al. For his dedicated transnasal endoscopy. The endoscopic pituitary surgery later became more national and it spread all over the world. And there have been leaders and pioneers all over the world. And then, of course, we have developed centers of endoscopic skull-base excellence in all major cities in these countries. Now, why do we select endoscopic endonasal surgery? Why is the switch from microscopic endonasal surgery to endoscopic? The reason is that in endoscopic surgery, you get a wide panoramic view. You have an improved illumination, ability to look around anatomic corners using angle tip, and also the use of 30-degree and 60-degree cameras. And you can use it for extended approaches for even paracellular tumors. So now the endoscopic skull-base surgery has developed in such a way that multiple lesions extending from the cribriform plate down up to C2 and laterally to the infratemporal fossa and petrous apex can be dealt in this route. It is an ever-ending, expanding spectrum of skull-base surgery. You can treat paracellular lesions, cellular paracellular lesions like pituitary macroadenomas, craniopharyngioma, epidermolysis, cribriform lesions like meningiomas, esthesioneuroblastoma, planum meningiomas, sinonasal carcinomas, clival lesions, chordoma, chondrosarcoma, and even vascular cases like basilar aneurysm clipping, spinomedullary junction lesions like odontoid lesions, nasopharyngeal carcinoma, pterygopalatine fossa lesions, meningiomas and schwannomas, paraganglionoma, and of course, JNA, juvenile nasopharyngeal angiofibroma. Petrous apex lesions are more and more dealt now, like cholesterol granuloma, chondrosarcoma, and there is across or transclival approach to the opposite petrous apex. Now, though we have so many approaches, finally the safety of any procedure depends on one, the evolution of a new approach, the surgeon's learning curve, which is more important, and the development of new equipments. And finally, the development of new techniques. And one more thing is that each surgeon should go through this learning curve. Though the science, the field develops, each one of us or each center should also have that expertise in this particular field of technique. Coming to complications associated with transvenoidal pituitary surgery, which is the main topic which I am talking today. This interesting article, which came in the neurosurgery journal, it's an experience of 1,000 odd cases of pituitary treated at a single center. They found that major disability is as low as 0.26 percentage. So what is more important is that though there is reduction in mortality, there is equal number of increase in morbidity. So just before, uh, Dr. Hasegawa pointed out that major complications are, one is surgical complications. I would like to classify in this way: surgical complications. The most common is cerebrospinal leak still. Neurological deficits, post-op hematoma, cranial nerve palsies. And finally, the most important thing is a carotid artery injury. And you can have a stroke without even having a carotid artery injury. The next important thing is a medical complication like sepsis, pneumonia. Endocrine complications are also more common with DI and severe hyponatremia, though we have good understanding of the disease and treatment available for this, and the outcome is better with critical care management. And finally, laryngeal or nasal complications, rhinological complications like crusting infection, septal saddling, these kind of complications. So this plethora of complications are there, but still the most dreaded thing is a carotid artery injury. Why are we so afraid of a carotid artery injury? Mainly because it is so devastating. You may even lose the patient there. The incidence of vascular injury is less, it is 1.1% in pituitary surgery. But as more and more cases of extended endonasal surgeries came, the incidence has risen to almost 10% in some series. The vascular complications, as I told you, carotid artery injury is the most dreaded, disastrous complication. Why? Because it can cause overwhelming blood loss and risk to life. It can form a pseudoaneurysm, vessel spasm, and thrombosis, all leading to stroke, sometimes embolism, even without thrombosis. And then formation of keratocavernous fistula is also very common. And then finally, hematoma in tumor cavity causing vision compromise. There are some risk factors for ICA injury, which we should always know to how to perform a safe surgery. We should be very thorough with the anatomic relationship. We should look for carotid dehiscence, the sphenoid septal attachment to the ICA. As you know, the sphenoid septum need not be midline in all cases. It can even deviate to one side and directly get attached to the ICA. And you can get wrong even in the first step of removing of the septum. Sometimes we have something called a midline ICA and or hourglass kind of thing, kissing ICA, where the intercarotid distance can be very less. Revision surgery, always a danger for ICA injury. Why? Because the usual landmarks which we look for need not be always seen. Prior radiotherapy makes the things difficult. Everything will be fibrosed, adherent. Even bromocriptine treatment can cause a shrinkage of the tumor and more adhesions, especially if the tumor is extending into the cavernous sinus. It's very difficult to get a total excision without compromising on this case. Acromegaly or GH secretion excess is one factor which is found to be associated with probable ICA injury. And we also know that sometimes aneurysms can also coexist in acromegaly. And of course, pre-existing vascular malformations, more important as you go more and more into skull-based surgery and extended skull-based surgery. So ensuring safety is more important in endonasal approaches as in any surgical procedure. You always stop, think, and act. Safety is first, and only the safe surgeons last. Always remember this. It's not just the patient, but also the surgeon who is a catastrophe in such an injury. So how do you select an endoscopic approach? One, the extent of resection should be equal or better than an open approach. Secondly, the approach that traverses the fewest neurovascular structures to access the lesion will be the best approach. For example, if you have to cross the cavernous sinus to reach something which can be easily reached from the lateral skull base, you should go for that approach than going through endoscopic approach. And the approach is safe when the disease has not spread beyond the limits of the technique. That is also very important how you select a case for endoscopic approach. A thorough anatomical knowledge is very important from the endoscopic perspective. This is more important for fellows and students who are starting endoscopic work. So you have to go through all the available literature. There are good guiding articles available, which you should always see. The most important thing is that you should have an endoscopic perspective to the ICA. Like you should understand that there is a parapharyngeal ICA. It will look or it will be staying in this part of the approach. The pitras ICA, the laceral ICA, and then most important is the paraclival ICA as we go into clival tumors, paracellular ICA, and then how the supraclinoid ICA, how these things are all related to the pituitary gland or whatever structure which we are interested in. So this kind of an anatomy you should be very thorough. But then we always know that this is a cadaver dissected specimen. There is always a bone hiding all these things. Now, what are the landmarks once we go endoscopically? There are good articles which deal extensively on this, on what are the landmarks in relation to the segment of the ICA. So I can summarize like when we see a pituitary tumor, MOCR or medial opticocarotid recess is the most important landmark here with this paraclinoid part of the carotid. And median nerve is where the carotid enters the cavernous sinus. These are the two landmarks we have to be very careful about. You may not see median nerve in all cases of pituitary, you may not dissect up to that level. But in all extended cases, we have to be very careful to identify the median nerve at the first instance so that you have a very good anatomical landmark there. And this is the safe zone. Now, coming to a team approach, we have to understand that so many people have to work synergistically for a good outcome for a pituitary tumor. Ophthalmologist or the neurologist who first diagnose and sends a patient to us, a radiologist and neurosurgeon always works together along with the otolaryngologist. This is a core team. We should meticulously review and plan. So see here the neurosurgeon is getting a help from a radiologist and otolaryngologist to cross this small gap. And then the neuroanesthetist, radio-oncologist and endocrinologist are most important in the post-op management of the patients. And now we have a new person in the team that is an interventional radiologist. We'll know how he comes to play. The role of an otolaryngologist, he's always a partner for a neurosurgeon. It should always be a good teamwork between these two. And he guides you to the cella without any collateral damage. Use of nasoseptal or other ancillary flaps for skull-based repair. You see, the role of otolaryngologist comes more when you have a difficult case. But then, unless you have a good team, how can you team up for a difficult case? And you cannot always anticipate a difficult case. Sometimes it may come out of the blue. So his major work is to abolish post-operative CSF leak. And this is also very important. I'll come to that later. Now, coming to the radiology team meeting, you should meticulously review the imaging as in any other field of neurosciences. And this article gives a very good guidance on how you have to do preoperative and intraoperative imaging. And we have a case here, a 64-year-old lady who presented with diplopia and left abducens palsy. And there was a lesion involving the left cavernous sinus. It was obviously compressing the abducens nerve. And then we always know that ICA comes very near to that. So we should preoperatively assess the relation to the ICA. So we have a team meeting to discuss the approach. We plan the investigations, and we do. And I'll show you how a 3D reconstruction can be done on the work table. So this is a case. You can see the CT angio here. This is the carotid. This is a lesion reaching up to the carotid. And this is an axial image. Now the radiologist helps you to do a 3D reconstruction. So you can see that this is the opening of the, this is a half of the sphenoid sinus. You're already into the sphenoid sinus, sphenoid septum is seen. You can see the lesion here. And then he can take you deep inside the sinus and exactly how you see endoscopically, who can work, all these things. This can be done even in a place where there is no augmented reality, even in your own CT or MRI, you can do all this kind of reconstruction on the work table. The only thing that we should have patience, we should have time, and we should have a good camaraderie to work as a team. Now, the endoscope, the radiologist also shows you from above, which we are more thorough with. This is the clinoid process here. And then this is a carotid from above. plenum sphenoide, and you can see the defect down there. So this is the advantage. And here, whatever you saw there, you can see here, destructive lesion. I'm using Doppler here, more safety devices. And then I can also use navigation to see the ICA. And finally, I can decompress the tumor. Now, navigation is one very important tool in skull base surgery, especially extended surgery. And we use it for all cases so that we are so thorough and accurate in using that. So this was a case of a sphenoid mucocele, and you can see that it's just inside the sphenoid sinus. But you can see that here it's very close to the ICA. The moment we remove the mucosa, we enter the mucocele. This is how you see thickened mucosa. And if you remove it, you can directly see the dehiscence in the ICA exposed. So these kind of cases, when you are not very sure of the anatomy or landmarks, navigation helps you a lot in reaching the ICA directly. Now, this is an ideal situation. I saw this article in 2015, like a 3D endoscopy in an OT with an intra-op MRI suit. Unfortunately, it's not the same or in all places. So we should learn how to improvise on our available resources and how to take the best out of it. And then ongoing critical re-evaluation of outcomes is essential for ensuring optimal result. So as in any other field of neurosurgery, endoscopic surgery is a good learning curve for everyone, because at each stage you are learning a new thing, you are going to a new approach. So you have to put a lot of effort on what went wrong. And this is an article which says how you have to learn in endoscopic surgery. So now I will share a few common instances of vascular injury in nasal surgery. So I have classified in where do you expect a vascular injury and how you can prevent it. So the first instance of vascular injury is while drilling. We all know that the most of the articles or the literature says that drilling should be very careful. You should always use a diamond drill, and it should be done under very great control. The bone work directly over the carotid should be very carefully done. When you drill over the carotid, it should be very carefully done. And if you lose the landmarks, then that is one for having an ICA injury. Thick bone, especially in acromegaly, again very careful while drilling. Erosive tumors, destroying the paracellular bony cover also. So this is one case we published in Will Cornell, and this was a case of tuberculum sella meningioma. And here we were drilling on the superior part of it near the tuberculum sella. And then we found that there was sudden bleeding, and the patient was packed and taken up for a vascular procedure. We could find the extravasation of the contrast in the anterior genu of the cavernous segment of the right ICA. They did a carotid occlusion test. There was a good collateral flow. The ICA was coiled, but the patient survived without any deficit because of the good collateral flow. So this is one thing we should be very careful while drilling. So how are we more careful? We should know that the ICA morphology can be of different types. It can be a trapezoid type, which is converging towards this side, apex, and it can be a square type, more useful, or an hourglass type, which is a type C, which is converging inferiorly. So depending on that, we should be careful on how we drill. So look for this exposed ICA, which I told earlier. The prevention is preoperative workup, CT angiography in selected cases, navigation with CT angio and MRI merged in such cases where we are likely to find difficulty. Cross-compression and balloon tests for very high-risk patients, especially when you have to cross that ICA and remove a tumor. Prior radiation or previous surgery, you should be very careful. And tumors with vessel encasement, you should be very careful. Now, after drilling, the second instance of injury is while opening the dura. Opening the dura over the carotid artery, again, very dangerous, especially when you miss the midline. And if you make a nick on the dura, you may be nicking on the carotid artery. I've seen one such case, especially in recurrent cases where you lose the midline. When you use a sharp instrument to extend the dural incision, and sometimes in functional tumors, it is more common to have injury of the ICA. As in this case, we have a 60-year-old gentleman. This is a T2 weighted coronal image. You can see the multilobulated tumor and very thick sphenoid sinus. And you can see here, it is very close to the ICA. The ICA is directly exposed here, and you can even see a good bony cover here. And Here you can see the bony erosion, and we use neural navigation, and you can see that where you're located. You can find out the midline. You can also find how close you are to the carotid artery. The other most important tool which I have is a Doppler. There are different kind of Doppler probes. These kind of bayonet-shaped Doppler probes are very useful. These are available, disposable ones. But we usually use a pencil-shaped Doppler, which can be directly kept here. The most important thing is that before opening the dura, the Doppler probe is placed at the edge of the bony opening at a 90-degree angle to the dura. Your idea is to find where the carotid is hidden there. And from there, if there is no audible flow, then you try to angle the probe more laterally, aiming under the bone edge. So if you then move the probe superiorly and inferiorly and look for ICA. So this is very important step we do before opening the dura in all cases. So directly over the bony dehiscence, you can see you can feel the carotid artery. Immediately after exposing the sphenoid, you can see the carotid artery. So once you expose the whole sphenoid sinus, and after doing all the drilling, sometimes there's a chance that you may miss the midline. So that is very important to do a Doppler there. The second most useful instrument which I saw from Pittsburgh is one thing called a feather blade round tipped knife. And this is how I use it for extending the incision laterally. You can see that the tip is rounded. It does not cause any injury, even if it touches any vascular structure. And it cuts only here after lifting up the tube. So now coming to the third injury, it is while dissecting the cavernous sinus component of the pituitary tumor. Sometimes firm tumors are adherent to the ICA, and you should always know when to leave a piece of tumor there than trying to remove everything. You can cause an adventitial injury there. And ICA encasing tumors should be very careful, and it's always a wrong technique of dissection sometimes. So you should know about this NOS classification and how much into the cavernous sinus our tumor is going, and you should revise the techniques accordingly. You should not try to remove a great NOS4 tumor directly through an endoscopic route. You should leave a part of it which you cannot reach for a radiotherapy. So we should be humble enough to accept and then proceed. So this is one of our case, which is NOS2 extension. And you can see that I always use only blunt instruments or blunt curettes for dissecting near the cavernous sinus. And then always remember to dissect the tumor away from the cavernous sinus. As in this case, this is the left cavernous sinus where I'm going. You can see this stage. I know that this is the cavernous sinus there. I already found out with the Doppler. And this is a part of tumor. I'm slowly dissecting it away very softly. And part of the tumor is suddenly sucked in. So once I finish that removal of that carotid cavernous component, I can see the carotid artery here. Can you see here? Carotid artery. This is the cavernous sinus area. And this is how I go step by step. Now I'll try to remove this part of the tumor. And before I do that, I'll just confirm the presence of the carotid artery using a Doppler again. This is how we remove the cavernous part. Now, this is one case which was shared by my friend. This is a 42-year-old lady with a recurrent pituitary macroadenoma with left cavernous sinus extension. And then this is a tumor, and you can see here he's going more laterally and not very sure about the cavernous sinus there, but you can see a tumor component there. So very clearly it is tumor. And then trying to dissect around the tumor. And he's using a blunt probe, but trying to dissect around the tumor. Now the dura is slowly moved from the tumor, but then suddenly you can see the gush of blood. So this is very dangerous. The technique of dissection should be, you have to decompress first. Now, once you have the leak, how do you fix it? That's more important, how to stop the leak. This patient was salvaged with nasal packing. She was rushed for angiogram, underwent a left ICA stending, and escaped with the left MCA partial infarct. But this need not be the case in all cases. The important steps in a surgical field control in such a bleed is two-surgeon technique working as a team or a binostril technique. So here comes the importance of an equal partner of an otolaryngal surgeon there. And dynamic endoscopic navigation, high power suction. Dynamic endoscope means the endoscope moves in and moves out to guide the surgeon. So that's very important. You cannot keep the endoscope in one place. You need a person who is very experienced in endoscopy, and that is the otolaryngologist. Devices that can be used for directly closing this carotid injuries, one a U-clip or something called a Wormald vascular clip. But these things are not available. You can see the jet of blood directly on a high power suction, and the clipping is being done here. It can cause ICS stenosis, but the general thing is that when you have such a leak, which is high pressure, take a muscle from the sternocleidomastoid and do a packing. You have to understand that Surgicel, Flow Seal, all are ineffective and even cause embolism. It's not recommended. Use the muscle from sternocleidomastoid, pack it with gauze or cotton, and take up for um, endovascular treatment. But in a low pressure venous leak in a cavernous sinus, this is very useful, Surgicel or Flow Seal. So the quote, right, or when you have a bleed inside your OT, identify the point of bleeding, place the muscle graft, use a cottonoid and pack the sella with gauze. Avoid undue compression. This is also very important because you may take 30 minutes to reach the endovascular suite and put a catheter there. But if you give 30 minutes of carotid compression, that can lead to stroke. So you should be very careful. Now, I'll go to the next kind of injury. It is small vessel injury, perforator and AC injury. These are more common in extended skull-based procedures, but sometimes in pituitary tumors that are going above, they can be attached to the ACA. And then vessel encasing tumors also, you should be very careful. We should always look for a cortical cuff around the vessel. What do you mean by a cortical cuff? You should have a brain tissue around the vessel, not the tumor tissue. Then only it's very safe to remove the tumor. And then never remove a tumor without vision. Whenever you're removing a meningioma or a suprasellar tumor, always make the tumor smaller, thin it to a sheet, and then only try to remove the last part of the tumor. Never pull down a tumor. Even though it may be very loose, hanging, don't pull it down. And then in open surgery, this is sometimes an indication for open surgery in some cases when you have an encasement of the vessel. And you can even leave a sliver of tumor attached to the vessel to prevent an injury. So this is how they look for a cortical cuff around the vessel. You can see here this kind of thing where it is not encased, it's cortical cuff. So here there is one case of an A1 perforator injury, and they used something called a VEC clips endoscopically to get a hemostasis, and a patient escaped with a small caudate infarct. Now here is an algorithm, and the first important is if the patient is a good candidate for antiplatelet, then you can go ahead and think about putting stent. But there are patients who are not good candidates for an antithrombotic treatment. So then you'll have to do a balloon occlusion test. And if they pass the balloon occlusion test, I see a coiling. If they don't pass the balloon occlusion test, what are the options? You can have a CCF or pseudoaneurysms. You can use many things like covered stent and coiling, pipeline stent, and sometimes coiling without stenting, which can always fail. In such cases, you should think of high flow ECIC bypass, at least in some cases where the endovascular treatment fails. Now, this is a publications about endovascular treatment for endoscopic skull-based surgery. They have increased over the years, and this is 1 decade back. Articles. Now, coming and summarizing the lessons learned from the arterial injuries are: one, avoid using ultrasonic aspirate near the cavernous sinus. Use of diamond burr is more important in sphenoid sinus, and some people say that bone cutting aspirators are more safer. Avoid pulling down on the tumor capsule until it is well dissected off the surrounding structure. Strictly follow internal decompression and extracapsular dissection. Dissect away from the cavernous sinus using blunt curettes, and never dissect without visualization. Now, there are some delayed vascular complications which can be due to carotid insufficiency. The other reasons of carotid insufficiency is one is occlusion or thrombosis, and the other thing which is recognized is vasospasm. Vasospasm can be due to multiple reasons. One is direct mechanical damage to the arterial wall when we dissect a tumor out of the cavernous sinus, blood in the basal cisterns, meningitis, release of some chemical substances during tumor removal, all are thought to be reasons for vasospasm. And then there are some articles of sodium fluorescent causing vasospasm when injected in high concentration, and when injected in rapidly, it can cause vasospasm. We have one case reported like that. And then in literature, 34 cases of delayed vasospasm has been reported. Now, DSA, you should always think of doing a post-op DSA whenever you have a patient with an unexplained acute neurological deterioration. For example, when a patient who had a very clean surgery without any vascular injury, pituitary surgery, gets up with a faciobrachial weakness, that is the first indication for DSA, because cerebral vasospasm is one thing that should be treated early and aggressively. You cannot wait till the infarct develops. Now, coming to infarcts without injury, we have two papers, one with Dr. Indira Devi and one with Dr. Sampath and Dr. Narsingh Rao. And the conclusion of these two papers is that increased cellular pressure due to compression, packing of the cella can directly compress the carotid. So you should always restrict overzealous packing of the cella during the floor reconstruction. And sometimes post-operative edema or hemorrhage in a residual tumor, especially if you have a tumor encasing the ICA and there's a bleed into the tumor, it can directly compress the ICA. So these were the two things we learned from these cases. And you always have a surgical checklist, which includes everything from anesthesia side, surgical side, equipment side. Very important. When you start in a new center, you should be very careful about having all balanced equipments ready in hand. And then one more thing is there, most important is the closure pause. Why is it more important, closure pause? I'll tell you why. We had a 25-year-old lady with a pituitary tumor who was operated. We had an intra-op CSF leak. We could repair it, pack it with fat, and then post-op, she had persisting CSF leak. Her vision, everything had improved. Only problem was CSF leak. So we thought of doing a conservative management. We put a lumbar drain and kept her for 2 more days. But then within 2 days, she developed fulminant meningitis, sepsis, and died. So CSF rhinorrhea is a very dreaded killer, which is next to a vascular injury, we should always say. So this, what I call closure pause, where you always see that you close properly is very important. So this is a very important adjunct called intraoperative fluorescent. How do you use it? You have to dilute the fluorescent which is available, and you can instill fluorescent. 10 microgram of fluorescent is instilled intrathecally, diluted in CSF, and the patient is kept in Trendelenburg position prior to the surgery so that the CSF is green in color. So when you have a CSF leak, inadvertent CSF leak during surgery, you can always make out and then close properly. And I should not stress more with all this experience that nasoseptal flap or Haddad flap is very useful in many cases. And I should thank the otolaryngologist for helping me, Dr. Rajesh, for this flap. And Dr. Abhijit was my previous ENT colleague. And this is another use of gasket closure with facial lighter, which I learned from Dr. Schwartz. And we also use fibrin glue finally to just cover the nasoseptal flap. So this meticulous closure is as important as dissection, and the neurosurgeon cannot just leave the table without assured of a good closure. And coming to nasal complications, they are important, but they are quite common and underreported. Immediate complication can be some bleeding like this. You can see this is the uvula, and this is how the anesthetist sees in the ICU that there is a bleeding. A minor amount of bleeding is always possible. You can just keep cold packs, start tranexamic acid, hydrate the patient, reassure, do suctioning, and prevent aspiration. The patient is conscious, you can ask him to swallow it. But then if it's more than normal, you should always think about the source of bleeding. Probably you may have to revise your nasal packing. It's always the raw areas of the nasal mucosa that bleeds like this. You may have to use better techniques like Evisel or kind of gel forms. for packing the nose instead of gauze. Delayed nasal complication like crusting. Crusting happens when there is a raw bone exposed. So in order to prevent crusting, you should always cover the bone with the other flap which you already raised. Infection, mucocele, and saddle deformities are the most important thing. You should know where to cut the septum, and mucocele is one thing when you have packed everything and created a recess like this. So when you make a nasoseptal flap, when you close the cellar floor, you should always keep it open so that things can drain. Now, age, is it a predictor of safety? World Neurosurgery article says that a patient, even in the ninth decade, can get operated if you're sure that the vision is going to improve, because the quality of life decreases very much without a vision. So, age itself is not a contraindication, but then you can safely operate if you strictly stay with the guidelines of surgery. Now, finally, I'll just go to what's new or what's adding to the safety in pituitary surgery and generally endoscopic extended skull base surgeries. One is the safety is maximized during surgery with intraoperative CT, MRI, and angiography. This is one thing which is available. And one smaller kind of fluoroscopy or angiography is ICG fluoroendoscopy. As like this, in this case, if you give ICG in which special fluoroendoscopy, you can see the carotid artery separately. It can be useful in some cases where you have to identify the carotid artery in the field. It's very useful. Innovations like 3D endoscopic system, which is not taken up in a big way. Endoscopic augmented reality navigation system, where you can see the image in your augmented reality during the surgery. Ultrasonography assisted endoscope again, and finally the endoscope robot. Because sometimes you need a robot. You always think that if I had a robotic arm, I could have removed the tumor from this side, or I could have taken the camera so close, because always we find a conflict between the camera and the instrument. Probably endoscopic robot, if it develops in a good way, can avoid all such conflicts and get a more safer and total complete tumor removal. Finally, as I end this talk, I'd like to leave this message to you. We should always know the limitations of the approach and, of course, your limitations with the approach. One, when you have a large tumor with significant paracellular extension, you should always think whether you could do a staging of surgery than trying to remove everything in one go. Purely intraventricular tumor like a craniopharyngioma without much cellular component. If you don't have a proper stereoscopic visualization, when you have a very narrow surgical corridor where the ICAs are all very close, when you definitely see a neurovascular encasement, and when you anticipate difficulty in controlling hemorrhage, in all these cases, you should be careful whether you should go in one stage or you should do staging of surgery or you should use another approach to this. Finally, we should always train yourself, and this article is very useful for a person starting endoscopic surgery on how to have safety in surgery. And always visit courses like this. This is a Pittsburgh course where I visited last year, and I'm sure that you have similar courses in all parts of the world, especially in Japan and China. And India, we always have skull-based courses in all of our conferences. And we have to go with this Spartan message that he who sweats more in training bleeds less in war. And here is most important or interesting thing is simulating an internal carotid artery injury. This is a very useful cadaveric perfused model, which we always can do in our workshops. If I'm putting this slide for teachers, you can include this model in a cadaveric workshop. Thank you very much.
Well, thank you for great presentation, Professor. So, brief. So Professor summarized the detailed lecture on how to prevent and manage complications, especially focusing on carotid injuries. He said that the important thing is to understand the risk factors, which include, anatomical factors and revision surgery and acromegaly and so forth. And, it's very important to have a multidisciplinary team and carefully review the imaging studies, having many devices available, including navigation and Dopplers to manage, vascular injuries. Particularly, I completely agree with your idea that dissection should be performed first before pulling out the tumor to avoid vascular injuries. I like that. So I think there is no questions from audience. But I have one question for you. So do you happen to have any experience with, microscopic transnasal surgery?
Yeah. I started in microscopic surgery, and then I
Perfect.
learned.
Then I would like to ask you, when comparing to, microscopic surgery, what do you think about the risk profile of the endoscopic surgery for pituitary tumors?
The major shift in endoscopic pituitary surgery is it take little more time because you have to prepare the field. Whereas in microscopic surgery, you just infiltrate the septum, make an incision, and your hardy speculum is there. So that is one difference which I found. But here in endoscopic surgery, we have a partner or the otolaryngologist who is always there to guide us, discuss with us, and that is a great thing in endoscopic surgery. And as I told in my presentation, endoscopic view is very close. You get illumination, you can go beyond the corners. And I've started getting total excisions of pituitary tumor with suprasellar extension with endoscopic surgery. And then once we finish or we complete, we master that pituitary ordinary tumors, we should go to the next level and we can start doing craniopharyngiomas and other skull-based tumors. And there is an algorithm like if you do 50 endoscopic pituitary, you can go to the next level of doing a skull-based meningioma, which you should start with a tuberculum cellular meningioma or a planum meningioma. So for all this, you need a good reconstruction, and endoscopic surgery helps you for that reconstruction because you can never imagine to take a nasoseptal flap with a microscopic surgery as much as you can do with an endoscopic surgery.
Great. So you didn't speak a lot about endocrinological complications, but what do you think about endocrinological complication? Because some says that endoscopic surgery may increase the risk of postoperative pituitary dysfunction. I don't know the reason, but because we can see too much. I don't know. What do you think about that?
As you told, the endocrine complications, medical complications, I didn't include much into this because I wanted to focus on the surgical aspects. But then you have to understand that endocrine complications are also due to the surgical misadventure. Why I'm telling is that if you go systematically, you can even see the normal pituitary gland, which is seen as a paper, like a sheet, on inside the cella if you carefully remove the tumor. So this better illumination and close view always helps me to prevent endocrine complications. Honestly, in my experience, I used to have more DI and complications in all my microscopic pituitary tumors because I was not seeing anything. I was just removing the tumor. That was my magnification in that. Whereas here, after the tumor removal, I started seeing the pituitary gland, which remains compressed. And definitely the pituitary vasculature is in such a way that the portal system can immediately dysfunction. And temporary endocrine complications are very common in any pituitary surgery. And that's more common in a craniopharyngioma when you go for a total excision. Permanent endocrine complications are less in my experience in endoscopic surgery. And I have many patients who were totally taken out of cortisol and thyroxine in a follow-up of 6 months to 1 year. And then it is how you operate. Just because there is a technique doesn't mean that you always have a good outcome. The thing is that we should try to learn on our mistakes, and we have to find out why the endocrine complications happened and try to correct it. That's the way to go along.
Very nice answer, sir. Thank you very much. My last question is that I think you can also operate on gamma knife, right?
Yeah.
What do you think about the indication of gamma knife, knowing that, sometimes surgery can cause, many complications? What do you think about that?
See, gamma knife again should not be the first option in a tumor that can be operated. The reason is that the results of gamma knife, especially in functional tumors, are not very good. So when you have a functional tumor, surgical cure or surgical treatment is the first thing we have to do. And then when we have tumors in close proximity to the visual apparatus, again, gamma knife has some limitations. That upper part of the tumor, you have to reduce the isodoses so that you always stay safe of the optic chiasm. So in such cases, the gamma knife again can be a problem. Gamma knife is particularly useful when you have a tumor going into the cavernous sinus. So when you have that gamma knife available in your center, you should always try to use it. And as I presented, I told you that we should always think about staging and other agents of treatment like gamma knife or even stereotactic radiotherapy, fractionated radiotherapy, when you have a very difficult tumor going into the cavernous sinus in close proximity to the cavernous ICA. So as I told you, gamma knife is not a first line of treatment in a straightforward case that can be operated unless you have a very moribund patient. But then in a moribund patient, we don't operate unless there is a visual compromise. You can even observe a tumor in a moribund patient with a small tumor. So the limitations of gamma knives, as I told, visual compromise is little possible, or you'll have to decrease the dose in the upper part of the tumors. That is, and that can lead to failure of treatment.
Great. Yeah, thank you very much. So we've learned many things from you. I think it's time to move on to the next session.
Thank you.
Okay.
Thank you, Dr. Raja.
We have a raised hand from Ben. Ben, would you like to ask something?
Yes, Professor, thank you very much for your very educational lectures. It summarized so many perspectives in terms of endoscopic transrenal surgery, and it really helped young neurosurgeon very much in learning this technique. I have a quick question, and I would like to ask, in your slides, you mentioned about there could be a delayed complication of the mucosals. So personally, I do not have experience with patients with mucosals, but there is also many people telling that there could be chance if, for example, if you do not remove the sphenoid mucosa completely or putting the nasoseptal flap in the wrong way. And in your experience, what are the causes of the mucosals, and how do you avoid it during the surgery?
Yeah, so as you only partially answered this question, the reason of mucosal is when you have a mucosa that is not removed completely, and when you have a very narrow opening of the sphenoid sinus, which you have not opened properly. In these cases, when the mucosa grows back, the sphenoid drainage is blocked, and you can have a mucosal. Again, in cases where you have a larger nasoseptal flap, which turns on itself and forms a mucosal. All these things I have experienced. The only guidelines is that you should have a proper planning of the nasoseptal flap. You should not have a long or very big nasoseptal flap. It should be tailor cut. Second, you should always try to be patient and remove the mucosa from the sphenoid septum, because sphenoid sinus, sometimes it's very difficult and it can be vascular, but then you have to understand that once you pack with adrenaline gauze, all this bleeding can stop. And we always use a debrider for removing the sphenoid mucosa. And there is one more instrument, kind of a bipolar coablator, which also is very useful to control the bleeding. So if you have all these things, we should always try to remove the sphenoid mucosa. And that is the advantage of having an otolaryngologist. because every day, day in and day out, they are treating mucosales and sinus problems. So in our case, there are many cases who undergo even androstomy, clearance of the maxillary sinus, because sinus diseases are all going together. So you can have a comprehensive treatment also along with that. Now coming to mucosal, once it forms, sometimes it can get infected. So you may have to give a course of antibiotics and see. And sometimes you may have to drain the mucosal and increase the opening than going to the cellar floor. That can be easily done by an experienced otolaryngologist.
Thank you so much.
Thank you.
Well, thank you so much. It was
Thank you, Dr.
a tour de force, Dr. Jagatlal, regarding complication avoidance in pituitary surgery. We are extremely grateful to you for teaching us elaborately today, and we look forward to our future associations for the ACNS. Thank you very much. So I'd like to thank the chair as well, Dr. Hirotaka Hasi, for your time and support for the webinar. So
Thank you, Dr. Asikawa, for chairing. Thank you.
So we'll move on to the second session, and I would like to hand over this podium to our second chair, Dr. Nakaota, for saying a short introduction and inviting Dr. Lin Jingui for his lecture.
So now we move on to the next session. I'm Nakaota from Sapporo Teishinkai Hospital, Japan, chair this session. So now I'd like to introduce the next speaker, Professor Lin Jingui, Ningbo University, China. The intraoperative acute thrombosis during STA-MCA bypass for moyamoya disease is a nightmare for cerebral vascular surgeons. So I hope his lecture will solve the problem. The topic of the lecture is analysis of rescue strategies for acute thrombosis in moyamoya patients during STA-MCA bypass. Professor, could you start your lecture?
Thank you, Professor. Hello, everyone. I'm Lin Jinghui. I'm from the first affiliated hospital of Ningbo University. I'm going to share my working experience. My topic is analysis of rescue strategies for acute thrombosis in moyamoya patients during STA-MCA bypass surgery. Vascular bypass technique is mainly applied to the reconstruction of cerebral blood flow and is used to solve various complex cerebral ischemia problems. The intraoperative patency of the reconstructive vessel is critical to the efficiency of the procedure. Between October 2019 and December 2023, 298 patients undergoing cerebral vascular bypass surgery in our neurosurgery department. This technology is applied to cerebral aneurysm, traumatic brain injury, brain tumor, moyamoya disease, and moyamoya syndrome. This is a famous 54 years old, certainly honestly for 4 years. I was grade 5. CT scan showed the subarachnoid hemorrhage. Our surgical protocol is STA-MCA, M3 bypass, and carrier artery clip. Let's see the video. This is STA, and this is MCA, M3, and we do the end-to-side anastomosis. Then we creep the anterior artery. The ICG shows the patency of the anastomosis. This is another case, female, 67 years old, unconscious for 2 hours. Hess grade is 5. CT scan shows the subarachnoid hemorrhage and enhanced the CT scan for the dissecting aneurysm located A2. Our surgical protocol is aneurysm resection, and A2 to A2 end-to-end anastomosis. We assess the patency of anastomosis using ICG. This is another case, a male, 69 years old. Headache was vomiting 5 days. CT scan showed the subarachnoid hemorrhage and enhanced the CT scan for the aneurysm located in the pica. Our surgical protocol is OA and PIC bypass, and then PIC aneurysm isolation. We separated the OA between muscles and then perform end-to-end anastomosis between the pica and evaluate the patency. Of the anastomosis using ICG. This is OA and this is pica, and we clip the artery of pica. This is a female, age of 54, repeated headache for 4 years, and ravaged for the 1 month. Enhanced CT scan and DSA showed aneurysm located in M1. Our surgical protocol is M2, RA, and ECA bypass. And the proximal M1 clamping. The location of the parent artery is dissected out, finished the M2 RA ECA bypass. It's M2 and there's a radial artery. We do end-to-end anastomosis. Then we access the anastomosis using ICG. It's the ECA. After we do the bypass, we do a proximal M1 clamping. And the CTA and the CT perfusion and DSA were done 1 week after the surgery. We can see the patency. Another male, 65 years old, headache with left limb weakness for 1 month. And the cerebral fin injured and during the craniotomy. We trimming off the venous stamp and do end-to-end anastomosis. This is a traumatic brain injury, a male 64 years old. Headache injury caused by a car accident with a confusion for 4 years. The vein was severely damaged and the vascular lamp. The lamb was found to be fulfilled with the thrombus after cleaning. After cleaning the veins thrombus, we anastomosis the vein with the end-to-end anastomosis. None of the above patients had intraoperative thrombotic events. 276 patients with Moyamoya disease undergoing the STA-MCA bypass surgery. We retrospected viewed the clinical and imaging data and follow up the outcome of 8 patients who developed acute thrombosis during the surgical procedure. We implemented the 3 different thrombolic methods to evaluate the optimal thrombosis management during the bypass surgery. The table 1 shows the clinical characteristic of the 8 patients. All patients have an end-to-side anastomosis of STA-MCA with intralapid suture. In fact, in the revascularization surgery of MMD or anastomosis method was also varied, include end-to-side anastomosis with continuous suture and interrupted suture, in situ bypass, and center-to-side anastomosis. 69 patients with Moyamoya disease undergoing the STA-MCA bypass surgery of end-to-side anastomosis with continuous suture, and 16 patients undergoing the STA-MCA bypass of double tubal bypass. This is 2 anastomosis. Certain patients with Moyamoya disease underwent undergoing the STA-MCA in-situ bypass of end-to-side anastomosis. Sometimes the superficial temporal artery is too short to flip both sides during suture. We use this method without flipping the vessel, and the vessel wall on the opposite side insuted in suit. Many patients with Moyamoya disease undergoing the single vessel double anastomosis for flow augmentation, which use a single STA donor branch for both proximal side-to-side and a distal end-to-side anastomosis. The single vessel double anastomosis for flow augmentation, which have 2 methods. One is the intraluminal and extraluminal interrupted suture. And another method is intraluminal and extraluminal running stitch. 5 patients with mosaic disease undergoing another method of side-to-side anastomosis. This is anastomosis. The superficial temporal artery was never disconnected during the separation and maintained unobstructed blood flow. Then we do the side-to-side anastomosis from STA to the MCA M4. It's also an in situ anastomosis. We assess the patency of artery using ICG. (192 patients with Moyamoya disease undergoing the STA-MCA of end-to-side anastomosis. We implemented the 3 different thrombolic methods to evaluate the optimal thrombosis management during the bypass surgery. Method 1 is re-anastomosis after thrombosis removal. This is thrombosis. The ICG show anastomotic occlusion, and we unpacking 2 sutures and at the anastomosis to review the precedence of thrombus. And we anastomosis after the thrombus removal. Then the ICG post-secondary anastomosis indicates the patency of anastomosis. This method offers a clear view of thrombus, color, and location during the surgery. Using forceps for extraction is more direct and efficient. Furthermore, the anastomosis was reopened immediately in the case of non-thrombotic closure, such as those cased by the suture-related construction. Method 2 is a local insertion of trophibin into the anastomosis or branch of the STA. This is the case. The ICG reveals the occlusion and infrared show the same. This is a branch of STA, and we injection tirofiban into the branch of the STA and the anastomosis. The ICG is inherent the restaurant patency at the anastomosis site. This method offers a clear view of the thrombus color and the location during the surgery. Method 3, superficial select intra-artery tirofiban infusion via a microcatheter. With the occlusion of the STA. For the confirm of the anastomosis patent of via DSA. And the ICG was employed to once again to demonstrate the restore patency at the anastomosis. The third approach did not disrupt the suture at the anastomosis. Therefore, compared to the first and the second method, it avoids the potential vascular endothelial damage and demonstrated the efficacy of thrombin in eliminating acute thrombus. Moreover, this approach minimize the procedural complexity at the anastomotic site and avoid vascular spans after repeating manipulation and vessel narrowing following the multiple suture. However, vigilance is necessary for intraoperative and post-operative bleeding complication in patients subject to this method. We did not observe bleeding complication associated with the tirofiban. Summary: our method of treatment was efficacious in acute thrombosis management. Intra-artery administration of the tirofiban seems to be a simple and effective treatment option for acute thrombus during the STA-MCA surgery. The small number of the patients the limitation is the small number of the patients who have undergoing treatment with this technique and rarity of the other studies may lead to an insufficient evaluation of the effectiveness. And the safety of this technique is limitations. High case cells are essential to evaluate this technique further. Thank you.
So, Professor, thank you for very great lecture. I was so impressed about your lecture, and the professor showed us 3 ways to how to recover the acute thrombosis. First is open the anastomosis and remove the thrombus and the anastomosis. Second is to open the anastomosis and flush by the tirofiban and the anastomosis, and others flushed from the other branch of the STA-MCA bypass or microcatheter and infusion to by the tirofiban. Yeah, very interesting presentation. And I have some questions. And at first, in Japan, we cannot use the tirofiban out of cell. So could you tell us about the mechanism of the drug of the tirofiban?
Our drug section is primarily determined by the machines underlying the thrombus formation, the recruitment and activation of circulating platelet and the formation of an initial platelet plug, which is frequently observed in intraoperative in white, occur in response to the initial tissue injury. Tirofiban is a non-peptide platelet GP2B and 3A receptor antagonist, which prevents the aggregation of platelet and at atherosclerotic site by inhibiting the blending of fibrinogen to platelet.
Thank you. So it's tirofiban is one of the antiplatelet agent, isn't it? Not the
Yes,
anticoagulant, just an antiplatelet agent.
It is a 2B3A antagonist. I understand that. That its mechanism of action is like GP glycoprotein 2B3A inhibitor. It is along with eptifibatide. It is used in coronary angioplasty.
Thank you very much. Now we have one question from Professor Ben.
Yes. Thank you, Professor, for your excellent lecture. I would also like to ask about the use of the tirofiban. What is the dosage of the tirofiban that you use, and how long is the tirofiban infusion in your case?
Dose of 50 microgram was used, and we tried two times.
How long is the infusion usually for one time when you infuse it via the microcatheter?
He's asking how long will you give? What time of infusion? Like how fast it is? Like single injection.
We only use it in the operative. We only use it in the surgery, and when the ICG shows the patency of the anastomosis, we stop using it.
Okay, understood. Thank you very much. Dr.
So
Hasegawa.
next question is from Professor Hasegawa, please.
Yeah, thank you very much. So yeah, thanks for providing, a variety of bypass techniques and, many methods to recover, intraoperative thrombosis. I'm curious about, how to select the anastomosis method from your perspective. You can do, side to side bypass or side to end bypass or, the complex bypass. How to decide which to use?
In moyamoya disease,
The reason of this question is because I probably simply just do, single or double bypass for just a moyamoya disease, but you have, many other techniques. So I'm just curious about the rationale of your techniques.
this question is very, very good. We use side to side and end to side method to treat the moyamoya disease. Most of people we do the end to side anastomosis. if someone we see that is ischemia range is 4, which maybe we select the method of the single vessel double anastomosis for flow augmentation, which can fill the two lobby of the cerebral.
Professor Ota, how is it in your place? What do you do when you have a acute thrombosis?
For thrombosis, when we met acute thrombosis, at first we administrate the systemic heparin for 3,000 to 5,000 international unit. And of course, massage the anastomotic site and push out of the thrombus other. And if it is difficult to recanalize, we reclamp and remove the thrombus and reanastomosis. But majority of times we can do manage by the systemic heparinization.
Okay, that is
Speaking
very.
about, can I ask one more question?
Please, of course.
For both, Professor Otter and Professor Jinhui. So speaking about, antithrombus and systemic medications, what do you think about the perioperative medications, especially in cases of moya disease?
Thank you for a good question. First, I asked about your question. We always administrate the aspirin before 7 days before the surgery, and continue.
Is it low dose or high dose? What is the dose of aspirin?
Just 100 milligram.
100 milligram.
Yeah.
Okay.
Because I don't know reason why, but many moya cases had acute thrombosis, and white thrombus occur in the anastomotic site, even if we can completely anastomose the bypass. So that we want to avoid the acute thrombosis, we do a systemic aspirin administration pre and post-operatively. How about Professor Lee?
We also use aspirin.
Okay. How many days before surgery?
7 days before the operation.
And do you continue it after the surgery?
Yes. We after the surgery, and one day after 1 day to use. Yes.
Thank you very much. So it was a wonderful session. I would ask Dr. Nakawata to say his concluding remarks.
So this was very great session. I was very interested in, and I enjoyed. Thank you very much. Now we close the session.
Well, thank you very much, and I will close this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both speakers of today, Dr. Jagatlat Gangadharan and Dr. Lin Jingui, as well as chairs, Prof. Hirotaka Hasegawa and Prof. Nakaota for the time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. A special thanks to my co-host, Dr. Ben, for joining me today. So until we all meet tomorrow online, it is bye-bye from all of us. Thank you very much for joining.